Hey Fabio,
Hey boss, what's
what are
going
you
on?
up to?
I'm just debating with myself. So, in epilepsy surgery conference, a lot of people keep throwing neurostimulation, and I think it's just they just flip a coin. I have no idea how the process of reasoning through it goes.
I see. We may need to bring in an expert to get you educated about this. Is Dr. Fisher?
No way, Dr. Fisher, welcome.
Dr. Fisher is the Math Professor and Director of the Stanford Epilepsy Center and EEG Lab. He's published 265 peer-reviewed articles, wrote 3 books on epilepsy. He's the past president of the AES, editor-in-chief of Epilepsia and epilepsy.com. Also, Dr. Fisher has led projects on the definition and classification of epilepsy and research on epilepsy devices, which we're going to talk about today. He also led clinical trials on DBS and tachycardia-triggered VNS. He cares for epilepsy patients at the Stanford Epilepsy Clinics and inpatient epilepsy unit. It's our honor to have Dr. Fisher.
Well, thank you, Fabio. Since you've made the foolish decision that I know more about the subject than your audience, I feel obliged to say a few words.
Please.
We'll talk about neuromodulation, which I'll use as a loose synonym for neurostimulation here.
And we'll divide this into 5 separate talks. The first is why we need neuromodulation and basically what it is. Then we'll talk about the 3 approved types of neuromodulation in the United States, which are vagus nerve stimulation, VNS, responsive neurostimulation, RNS, and deep brain stimulation, DBS. And then the closing talk will be a comparison among those 3 and how to choose.
So let's get going. And yes, I do expect irreverent interruptions during my talk, so feel free.
We're good at that.
I actually don't have any recent disclosures relevant to any of these 5 talks, but over 3 years ago I took some educational funds for Medtronic seminars, and I've led a couple of studies with money to Stanford, and I have a series of irrelevant, basically non-paying disclosures.
So why do we need neuromodulation? Most of you probably know that epilepsy affects about 1% of the world, and 1/3 of those people are not adequately controlled by medications. You might think, okay, 2/3 is pretty good, but the number of uncontrolled people in absolute numbers is larger than all brain tumors, all multiple sclerosis, all muscular dystrophy, and all amyotrophic lateral sclerosis. So it's not a solved problem. The mainstay of treatment, of course, remains anti-seizure medications, and this is one method of choosing the medicine. The unblinded single-tailed test, although most clinicians choose it on the basis of either efficacy, but even more so, side effects that we don't want the patient to experience. If they're fat, we don't want to put them on a drug like valproic acid that's going to make them fatter. In the United States, we have 27 approved anti-seizure drugs or seizure medicines, ASMs as they're now called, not AEDs. You kind of know that if we had one that was great, we wouldn't have 26 other drugs. So as I mentioned, they only control seizures for about 2/3. They have a lot of side effects, cause birth defects, have drug interactions, require blood tests. Compliance often is poor and they're expensive. So you may say, why not do surgery? Because surgery can sometimes cure epilepsy. The meds don't. Problem with surgery is that it's only useful for a person who has one seizure focus that can be localized and designated to not be in a critical place that the patient needs. We don't want to remove the piano lessons. And sometimes localizing has its own risks. Can be invasive with, this happens to be a subdural grid, but we also use depth wires. I pronounce that carefully because one of my patients at Johns Hopkins thought I was saying death wires and refused to sign the consent. And then even with all of that, about half of them remain seizure-free, which is not a cure at all.
Mm-hmm.
So what if this is your patient? You tried 6 seizure medicines, 4 didn't work, 2 had bad side effects. Seizures come from both temporal lobes. They're not a candidate, therefore, for resective or ablative surgery. What do you do next? Well, I went to a lot of seizure conferences over the years where this was a common story, and the answer was sort of a shrug of the shoulders. That is very rare. these days because of neuromodulation. We almost always can at least try something to help with neuromodulation. Now, I should say before I forget to say it, that if a patient is still a good candidate for resective surgery, for example, laser ablation of mesial temporal lobe on one side, I still consider that a superior alternative because it does have the possibility for cure. And everything else that I'm going to talk about in this series of talks is almost always palliative, but not curative. But it is rare for us now to say there's nothing else we can do. And in fact, most of our weekly seizure conferences are now arguments about what type of neuromodulation to use and where to put it. These are the approved places for doing neuromodulation in the United States. The vagus nerve, first studied by Eleanor Ben-Menachem way back in 1994. So it's been around for a long time. I did the update study of automatic stimulation with tachycardia sensing, which is their latest device. And then I led the trial of the anterior nucleus stimulation, which we'll talk about, and responsive neurostimulation of the seizure focus, which we'll also talk about in some detail. There are a lot of other areas that have been stimulated in people, even more in experimental animals. And there are some that I think will probably come to approval after some large studies, including centromedian thalamus for Lennox-Gastaut types of syndromes, and hippocampus for hippocampal epilepsy.
Let's say you have a patient with either generalized epilepsy, or it's multifocal, or they just don't want resective or ablative surgery. Do you still use the failure of 2 anti-seizure drugs to consider neurostimulation, or is that different?
It's not different. That is a minimum to consider surgery, I think, or neurostimulation, assuming that there are 2 drugs that have been able to be used up to therapeutic dose. That's the ILAE, International League Against Epilepsy, definition of drug-resistant epilepsy. But almost all of these patients that we do surgery on or neuromodulation on have been on more drugs. Having said that, I think we ought to think about doing these treatments at an earlier stage and not 15, 20 years down the road as they've continued to have the psychosocial consequences of frequent seizures and health consequences. How does neurostimulation work? The answer is we don't know, and I should probably just stop there. But you can look over the list of things that have been argued as being part of the mechanism of neurostimulation. It does desynchronize the EEG. It does increase inhibition over excitation. But unlike neuromodulation for, say, tremor and some movement disorders, which works right in the operating room as soon as you turn the stimulator on, neuromodulation for epilepsy, be it VNS, RNS, or DBS, improves over time. Why is that? Well, that's where a lot of animal research papers have speculated. It does affect synaptogenesis, glia, inflammation, BDNF, receptors in various parts of the brain, but we don't know, although that's a universally recognized fact that improvement occurs over time, and something we have to warn the patients of so they don't come back after 3 months and say, hey, I'm still having seizures. I remember back years ago when we had to design the trial to test DBS, and the company says, okay, what settings should we use? Parameters or settings for the device. Ones to consider would be, where do we put the stimulator? How wide are the pulses? What's the frequency? What's the amplitude of the pulses? Do we use bipolar versus referential? How long do we run the stimulus train? And what type do we do? Should it be continuous, discontinuous on a schedule, responsive to stimuli, or some combination of the above? Now, those of you who are mathematicians and can do factorial math can calculate the number of possibilities that would generate, but it's very high. So my advice to those of you who plan to go into early stage clinical trials and design trials is just learn how to be a good guesser. Fortunately, we guessed pretty well in most cases, although I would have changed amplitude and not started so high. From a practical standpoint, who's going to be a good candidate for neurostimulation? First of all, I ought to have epilepsy and not one of the imitators. All of us in epilepsy surgery programs have had patients sent to us for epilepsy surgery who don't have epilepsy, but who have one of the many imitators. And that can be a hard conversation. They should have had at least 2 good trials of medications that didn't sufficiently help, and usually more. That's what we were talking about a few moments ago. They have to be not a candidate for, or they don't want resective or ablative surgery. Someone might be a good candidate in terms of getting rid of their left mesial temporal seizures, but not want to take a possible hit on their word memory. So they say no. Then they become a candidate for neuromodulation. They have to be willing to undergo a mildly invasive but still surgical procedure. They have to be able to present for regular follow-up and programming, and they have to be a patient willing to accept slow improvement. So the ideal neuromodulation would have all of these factors: safe, effective, non-invasive, convenient, no stigma, not walking around with something on your head, can penetrate deep and superficial into brain, can be focused to a specific target, easily available, simple programming, covered by insurance, and inexpensive. No such modulation exists at this point.
Just to summarize, make sure we understand, Dr. Fisher, essentially for the young trainees and early epileptologists out there. So you try meds, so you make sure there's epilepsy first. You try your meds. You try the appropriate meds at good dosages for at least 2. And once you hit that point, you consider surgery. The first tier would be resective or ablative surgery if possible. And if the patient doesn't want that, or it's not a good candidate for resective surgery, then you start thinking about neurostimulation, and we fall into these 3 options. Is that fair?
Gosh, I could have just said that and saved a lot of time in this talk. In the subsequent talks, we'll go on to hone in a little bit on the individual possibilities and then close with how you might decide to use one versus the other.